We're instructed to make sure we stay on time, to not mess up the whole schedule, so I will endeavor to do that and welcome you all to our session on transforming dialogue through the inclusion of community voices, a topic that's near and dear to not only my heart, but everybody on our fabulous panel that we have. So, of course, acknowledging that I'm an uninvited guest on the ancestral territory, ancestral unceded territory of the Squamish, Coast Salish, or Salish and Tsleil-Waututh Musqueam nations. I myself actually come from the Coast Salish Nation, specifically the Homokiming-speaking and Shinkotan-speaking people, also known as Salt Spring Island, and very grateful to have lived and worked there for the past 25 years. We're really delighted to have this opportunity to talk about community engagement this morning. We're going to be talking about community engagement from various perspectives, from a theoretical to an applied perspective, and how we're doing it across British Columbia. And I know that there's lots of very, very excellent community engagement work happening. So hopefully a lot of this will be confirmatory to your efforts as opposed to anything new. So I'm going to start off right away by defining community engagement. And of course, we all have a sense of what community is. We all have a sense of our shared experiences with people, either geographically or of like interest. But engagement is a little bit different. So in this instance, we're going to be talking about pragmatic engagement for health services planning and research. So not too much about research protocol like participatory action research or community engaged research. As we heard this morning, we're off to a good start. We're doing pretty good with the help of SPORE and TCPS2, of course. But instead, we're going to focus on engagement more from the perspective of health planning and policy. So one of the challenges with engagement is that it's poorly defined often and not well documented, which means identifying whether or not we're doing it becomes a little bit more difficult. Despite this, however, we know that appropriate engagement with communities is critical for quality improvement initiatives. It's critical for improving population health. But this general ambiguity is a bit problematic. So the formal definition that I'm going to be using is one from Fagan and Doler, and they say that communities collaborating with other partners in the planning, design, governance, and delivery of health services to tackle health-related matters that promote well-being. And just a note, I did replace the original quote, which was stakeholders, in order to avoid the colonial association of the use of the word stakeholders, which of course refers back to people using wooden stakes to claim land prior to any treaty negotiations with Indigenous communities. So I'm going to do a quick overview to summarize a bit of the context for community engagement from the evidence, from the growing body of evidence actually on its importance. And you might be aware of a lot of this. The benefits of involving communities in the design and planning of health services and quality improvement are really clear. Evidence shows that community involvement can have a positive effect on health awareness, build community capacity to respond to health issues, and can improve the acceptability and ownership of communities and patients to their health services. These data are pretty clear and, by my read, quite convincing and robust, but I want to turn for a minute to focus on why it's useful to consider community as an entity of engagement. So, actually I'm going to wait. So at its most basic, community is the container of shared experience for people, with a caveat, the important caveat, that there's going to be different experiences within the community, depending on an individual's positionality, so their background, socioeconomic status, characteristics, gender, age, ethnicity, all of these things create and lead to different experiences. So the subcurrent of diversity within communities is something that's really important to capture when we start talking about community engagement. And on our panel, Jane is going to be talking a bit more about this in more detail. So some consequences of lack of community engagement are pretty significant. And the first one I'm going to talk about is lack of relevance of policy. And I'm going to give you an example. During COVID, in one of the health authorities, the decision was made to shut down, as you all know, to shut down elective operative care. And this made a lot of sense for the bigger hospitals where they needed to redeploy staff to make sure that there was people to look after the very, very sick COVID patients. However, it did not make sense in the small communities who, number one, didn't keep any acutely ill COVID patients. They were all transferred out. And number two, couldn't redeploy the people in their small hospitals because it would mean them leaving the community, and that was entirely impractical. So there was a lack of local relevance, and it created a lot of dissent and ultimately led to very difficult catching up on wait times afterwards that could have been avoided. There's diminished trust and resistance. I'm going to talk a little bit more about this, non-compliance, when there's a lack of transparency, when people don't know what's happening. And we saw this through COVID. We saw this through people starting to push back against COVID vaccines, etc. Some of it, not all of that, had to do with a lack of transparency and understanding of the process. There was a lack of engagement. The other thing that I'm really interested in is lost opportunities for innovation. Rural communities, out of necessity, come up with innovative solutions to health services problems in low resource communities. They figure things out. They would like those innovations shared across a larger expanse. And when we're not engaging to learn about what's happening in individual communities, this is really difficult. So I'm interested in looking at and in considering just for a minute how we're doing with community engagement across the province. And this came out of a survey, this interest came out of a survey we did a couple of years ago around rural health priorities. Nothing that we found in the actual survey was unexpected. However, the open text comments mentioned over and over again lack of connection with policy and decision making, and this was an unsolicited response that was thematically relevant. People were talking about lack of engagement with health authorities. So we'd been thinking about that quite a bit. And of course, some of the challenges that come with lack of engagement, I believe, in observation started when we regionalized in an ironic way, because of course regionalization, which was one of the primary recommendations out of the Royal Commission on Healthcare and Costs in 1991, familiarly known as the Closer to Home Report, found that policymakers were alienated from patients and residents' experiences, and that there were very few mechanisms of accountability. So the report went on, of course, to recommend that we restructure in terms of regional health authorities so we can be more aligned with what the specific needs are in the communities. We know that this didn't exactly happen as planned, and what happened when we regionalized is a regional centralization of decision-making with, in some instances, not all, the continued alienation from the needs of smaller rural sites. So it's been a bit of an uphill battle for sure. Just to talk about quickly the difference between community and patient engagement, of course, is that patient engagement is actually has a different perspective. And I'm going to get to that in a minute, whereas community engagement is more of a collective perspective of shared experience. Patient engagement is really about quality improvement in healthcare. Community engagement is about health planning and health restructuring and transformation. And they're quite different and distinct, but they're also both mutually beneficial and have to work in synergy. So it's not like one replaces the other. They're both really important. But the question, of course, is why are we talking about community engagement now? Why has it become a mandate, not only of government, but of local, organized, and vocal community groups? And my observation is that there's a few things that are happening in BC. So we've seen significant health system challenges leading to diminished local care, and we know that every day when we see how many communities are on diversion, either because of maternity service closures or emergency service closures. We all know that solving this problem isn't straightforward. It's very complex and reliant on so many moving pieces that are way beyond the influence of local government and even regional government. However, there's an increasingly loud protest voice coming from rural communities who feel they no longer have a voice in what their solutions are going to be. So before we jump to engage in community engagement, I want to just point out and acknowledge that there's certain things we need to think about, of course, when we're engaging Indigenous communities. I'll just go with some of the high notes, underscored, of course, by the importance of respectful relationships, but let you know that Jane's going to be talking a little bit more about this through engagement through a diversity lens. So relationships built with communities, with Indigenous communities, necessarily need to prioritize connections with Indigenous leaders, elders, and community members to establish partnerships. It's based on the understanding of the need for respect for elders as cultural knowledge holders and decision makers. So we prioritize safe engagement and safe follow-up around the engagement process. There's obviously so much more to say about this, but I just want to do a call out that we need to be particularly mindful when we're engaging Indigenous communities. Okay, I'm going to finish off just with a few notes on principles of engagement. I'm not going to go through them all, but these principles come from the consolidated work from declarations like UNDRIP, the WHO Declaration on the Alma Ata, the Primary Care Declaration, and the International Association for Public Participation Core Values. I'm not going to go through any of these, but just to emphasize that public trust is essential when doing healthcare transformation and healthcare building. So I'm just going to scoot forward a little bit. We've done a recent survey on what the gap is between taking community data and evidence and turning it into policy. We're just wrapping that up. It was funded by the Social Planning and Research Council of BC. It's called the Gap Analysis. And here's a quote from some of the folks that we've talked to. There's a lot of interest, and it was interesting that this question was asked this morning. There's an awful lot of interest in engaging with communities by policy and decision makers. There's a couple of log jams, and one of them is doing it off the side of one's desk because people are incredibly busy. The other one is what to do with the yield of that engagement, and hopefully we'll get to that a little bit more on the panel. So I'm going to end with, we don't have time for that. What I'm going to end with is some questions that hopefully our panel is going to be working on addressing as we think about community engagement. So obviously it's based on an undercurrent of respect and authenticity, but some of the things we can think about is how do we ensure inclusion and representation? How do we integrate the yield of community engagement into healthcare policy and programs? How do we handle disagreements and conflicts within the community perspective and institutional perspective? And how can communities and advocacy groups effectively collaborate with healthcare decision makers to promote community engagement? So hopefully either this will be addressed to the panel or in the discussion afterwards. And it is my absolute pleasure to introduce my colleague and friend from the BC Rural Health Network, Paul Adams, who will be talking from a community perspective.
Good morning, everyone. Thank you, Jude, and thank you to the rest of the panel for joining us today. I think we're going to have a great conversation. I have one slide, so I'm not going to be flicking through it. And humor is a good medicine, so there's a few little hidden gems within that poster, and there's a reason for this. So I'm going to tell a story about the picture the image that you see on the screen. But more importantly, it is a real concern for our organization and for many rural communities in BC about the level of disengagement that has happened and the lack of community voice that is currently going through into policy, and recognizing the unique nature of all the individual communities in British Columbia. So in rural BC, we tend to concentrate on 180 or so communities which are RSA designated, which are Rural Subsidy Agreement designation, when in reality we have over 1,000 communities, and some of them have no primary care services, some of them have sporadic primary care, and we've all seen in the news cycles on the closure of emergency rooms and emergency departments. And we believe strongly that putting patients first requires the engagement of community voice, because that's where you really see good information coming in regards to solutions-based approaches. And our group, the BC Rural Health Network, is a pan-provincial organization that has representation of municipalities, regional districts, individuals, and a lot of NGOs. And we're all working for the same purpose, which is provide solutions and not just problems. So we don't come to the table looking at what to complain about. We come and explain the problem that we face as a community, and then we try and support that position through research and data. And that's where my connection with Jude Kornelsen has come from, is the amazing work that she's done for the past 2 decades on putting the data behind the policy positions that we're championing and bringing forward. So in order to engage effectively and in order to change the mindset, I think we have to look at the fact that a patient experience is a personal one, and it's a perspective, where community engagement is not a personal experience, it's a community experience. It provides solutions, it provides knowledge, and it provides expertise. Unfortunately, as Jude mentioned, through the regional centralization of services, we've done more than just take high acuity care and put it into regional centres, which makes a lot of sense from the standpoint of delivering services for high acuity situations. But we've also stripped out low acuity care. We've stripped out community leaders and champions. We've taken the knowledge holders and the people who provide good information up through the community, and we've sidelined that. And we see it, and I experience it every day. I'm out reaching out to communities, trying to provide good information. I get labeled as being, working for the government, that I'm a conspiracy advocate, that I'm, again, working behind the scenes to do damage, when in fact what I'm doing is putting out science and good information and re-engaging with community. And it's a very challenging process to go through that. And I get a lot of pushback, I get a lot of negative comments, but at the same time I get a lot of community support in rephrasing the top-down approach and coming to the community from the bottom up. And an example of that, and the problem with centralizing the regional management of our systems, not just healthcare, but rural systems generally, creates a situation that's depicted on this slide. So this is almost 2 years ago now. This is my community. I'm in the unceded traditional territory of the Silks people in the Upper Similkameen, just outside the community of Princeton. This is Princeton. We didn't have me in the river with my help sign. And the grizzly bear was not there, and nor was the ambulance. But there is a lot of, the rest of the picture is accurate, and this was almost 2 years ago now. And it came on the radio, 7 o'clock in the morning, CBC, my regular tune-in, and I'd been watching social media all night, and I'd been watching the water levels rise, and mayor and council, our volunteer fire department, all of the people who were community leaders were engaged in actually recovering from helping people get out of the flood situation, physically sandbagging, doing the things which were needed in that moment. On comes the radio to make the news in the morning, and they bring in the regional emergency manager. And they ask the emergency manager, there seems to be some flooding happening in the Upper Similkameen and the Tulameen Basin. Can you tell us what's happening? And on the radio, the emergency manager says, yes, there's 3 homes in Tulameen which are currently suffering flood conditions. And literally at the same time, I'm looking at these images coming across on social media. So I have a contact with CBC in Kelowna, and I send a message, and I said, good morning, but the reality on the ground is that this is happening, and that we have literally our entire downtown core underwater. We've got about 1/3 of our housing which is being impacted, and that people are literally on their roofs and cars are washing away. And here's some pictures. And this is via email, and the email comes back and says, well, we need somebody who's an expert to provide that information. I'm like, I live here, how much more expert can you get? And he said, well, it's just the policy of the CBC that we can't just put out information without having it verified by an expert. So again, I'm taken aback, and I said, well, what are you going to do? And he said, well, I'll reach back out to the manager. We'll get him to come back on the radio, and he'll clarify the situation. So an hour later, the manager comes back on the radio, and the manager says, To my best of my knowledge, we have 3 residents in Tulameen that are currently underwater. So it's just, again, and this slide reflects that disconnect, and it's happening not just in emergency services, it's happening in healthcare planning, and it's happening throughout rural BC, and we really need to re-engage with rural community. And I shall hand it back to Jude Kornelsen.
Thank you, Paul. And I'm delighted now to introduce Jane Osborne, who's going to be talking about community engagement through an equity, diversity, inclusion, and belonging lens.
All these tall people around me. Okay. Isn't that beautiful? That's the north end of Vancouver Island. I do live on Vancouver Island. I just want to start by saying Aitsquale, Aikwanazilamnala, in the language of my neighbors, the Staminas, the Snuneymuxw, and the Snitnawas peoples. I'm white, very. My ancestors are white Western European. I have come to understand, though, over time, how few of us, including me, especially me, coming from that kind of environment, fully understood my privilege, fully understood the impacts of being a white older woman. You know, it's all good. So just a bit. So I'm going to speak from these different perspectives, but we'll just start with, I lived a heteronormative lifestyle most of my life. Yeah, Jude's putting up those questions I was asking myself. Thank you, Jude. For more than half of my 77 years. And it functioned very well for me. And part of the reason I did that is because it felt like the natural thing to do. I lived with a white supremacist after my father died, patriarch, psychoanalyst, and there were certain norms we had for gender. Like, you know, women do this, men do that, da-da-da-da-da. Okay. So the dishonesty that I lived with for that first part of my life was rewarded in my professional career. I worked in IT. I had no difficulty getting employed. I had no difficulty in staying employed, except I kept leaving jobs, but that was what you did in IT back then. But my mental and emotional health suffered incredibly, and at age 38, it all collapsed in on me. So fast forwarding now to 25 years to when I claimed my fluid queer senior identity, it created discomfort for the colleagues I had in my organization at the time. And I was actually pushed out of the organization that had been my life's work since 1998, along with some other folks. And that organization wound up poorer for it. I'm still dedicated to adult abuse and neglect and prevention. I was working in community side of adult guardianship, and I work closely, I believe totally, in collective collaborative work with health, with public guardian and trustee, with police from my restorative justice perspectives in the background. You know, it was my life, and it's still my life. That's the good news. So the experience of being pushed out because of identity turned out to be so positive. In fact, every really rotten thing that happened to me over my life turns out to be very positive because it connects me and it puts me in relationship with other people who might have been marginalized for one reason or another, pushed out for one reason or another. So what I'm able to do now is support many other people that have similar experiences to me. So I just want to talk a bit about how I experience our professional world. We'll talk generally, academia, medicine, justice, law, accounting, you name it, okay? It's often led by well-intentioned people like me, right? I was the IT manager at Metro Vancouver for a period of time, and I had learned how to successfully navigate the colonial waters, right? And that really allowed me to maintain the dominance of the way we do things, which is, you know, what your bosses like you to do, okay? And so, but it also led, of course, in the case of Canada, to the cultural genocide of Indigenous populations, and that's all around our world. We tend to think in terms of Turtle Island, but I'm working with a colleague now who's an immigrant from North Philippines, Filipino, who has experienced exactly the same things. So what change is needed? At a macro level, I think we need to look at our professional associations. Most of us who work professionally, whether nurses, doctors, not so much IT, they tend to be a bit maverick. Sorry, guys. Did I say that? And they sort of define and enforce what's deemed ethical best practice. Ooh, okay. Evidence-based practice, okay. So we got to ask ourselves questions like, what do we need to change to embrace diversity and validate other ways of knowing? What would that look like? It wouldn't look like what we're doing right now, I don't think. So segueing back where I'm supposed to be into health, what have I seen in health service delivery? Around this province, because I've worked provincially for quite a few years now, my young queer trans, especially when intersected with indigeneity, and Black friends and colleagues continue to experience very negative treatment in health settings, particularly in rural and remote settings. My First Nations, Métis colleagues continue to experience traumatic losses at the hands of colonial systems of health and justice. More generally, my Black, brown, and queer friends and colleagues routinely experience microaggressions and sometimes more serious racist or homophobic attacks. I am white. I pass as heteronormative. I don't experience this. It doesn't happen to me. Are these impacts worse in rural or remote? Absolutely, definitively, yes. I could give you samples, but that's not my job. I'm not here to speak for others. We're all trying to figure out how to listen to others, to communities. In urban settings, we have a lot of organizations. We have a myriad of supports. We create collective mechanisms of mutual support. In rural and remote, these do not exist to the same extent, if at all. And rural and remote can be just up the island from me on a little, like Sointula, for example, which is a little white Finnish outpost on the east side of the island. It may mean that people seeking supports need to move. And this is not health equity. If the people have to move, or community equity, something's not working. So what is our task, particularly in rural and remote regions? In my view, it's to do our own work around understanding our privilege. And I have to say it's taking me years and I'm still not there. I need my friends, my colleagues to remind me, of where we are in this work, and we're not far enough. So we have to support decolonization initiatives, particularly those led by local First Peoples, local QT BIPOC folks, and it needs to be supported and resourced in some way by our province, more significantly than now. In rural and remote, we need to create safety for communities of marginalized people to speak their truths, which means additional resources and training attached to, hopefully, funded rural community health centers. I've seen many wonderful examples of rural community health centers, and they work absolutely great. But most of the time, they have been funded by the local population. That Gabriel Island would be a sample of that. Finally, we need to develop those mechanisms to evoke and hear direct feedback from patients, caregivers, and community members who do not enjoy privilege. And that means more resources for community health stakeholders who do this work. Oh, wrong word. Thank you, Jude. I will not use that word again. It's going out. Do this work supported by trained and experienced consultants. And the reason I focus on community is I can tell you right now that the queer trans youth that I am working with, one of whom I'm a health representative for them under our adult guardianship legislation, they are not safe. They are not safe unless they are surrounded by their supportive community. They don't want outsiders, people coming in and saying, I'm your ally. They want to say, you're my ally. And so we have to think about, what does that mean? Communities go beyond regional and geographic communities into communities of care and support networks. So, Haichka, Chachalcheko, that's the New Chalmouth, Gilakisla, Megwitch, thank you for listening.
Thanks, Jane. I'm delighted to introduce Valerie St. John from the BC Association of Community Health Centers, who's going to be talking about how BCACH has actually worked in community-directed health service planning to their model. So here we are. Oops.
Yeah, that's good enough.
That wasn't your first slide, was it?
It is missing a logo, so it's good, yes. Not a problem. Hi, yeah. Oh, wow, there's more of you than I saw stuck in my little alcove back there. Awesome. I am delighted to be part of this panel today and to talk to you about the community health center model of care delivery, and emphasis on community there, apropos of the conversation today. So what is a community health center, just in case you don't know? We use 5 principles to define a community health center as being different from other care delivery models. And so first principle is that there's team-based care provided using an interdisciplinary team. And I'll give you some examples of what that looks like. There is an integration of services that includes primary care, health promotion, and community well-being. So anything that is a program supporting the social determinants of health can be delivered through a community health center in addition to primary care. A CHC is community governed, so it's a nonprofit, it's a cooperative, it is something that is developed by community for community. It actively addresses the social determinants of health, I believe I said that already, and there is a very priority focus on the commitment to health equity and social justice in the model and by the care providers and the community participants in a CHC. Give you a sense of where some of these are in the province in case you haven't stumbled across one in your travels. So by health authority organized region, we have a series of CHCs listed here by title. Anything that is in the bold is in a rural setting, and anything that has a small e beside it in brackets is an emerging community health center. So this will be a community that my association is working with to help them to develop a community health center by doing a gap analysis, needs assessment, what kinds of services do they want to provide, what partners are they going to integrate with, et cetera, et cetera. So this gives you a sense of where some of these CHCs are and some of the emerging ones in particular. And the key here is working with community to develop the gap analysis and the service delivery model. So here's 3 samples of CHCs around the province. So Kool-Aid's in Victoria, Umbrella Multicultural Co-op is in New Westminster, and Galliano Island CHC is on Galliano Island. And so each of these communities has decided what services they need for their service population. And they've decided what sorts of practitioners they want to have in their team-based care model. And they've also decided what sorts of other agencies they want and need to partner with in their community or in their region to provide integrated service delivery. And so that's another key principle of the community health center model, is really taking stock of what's in a community and figuring out the gaps and figuring out who to partner with to deliver services. All right, so what does my association do? We call ourselves BCATCH, which is the BC Association of Community Health Centers. So BCATCH works with communities or agencies in a community who are interested in developing a community health center, and we provide them with a starter kit, which gives them a sense of what do they need to do, what research is necessary, what gap analysis is necessary, what tools and templates can we support them to use to identify what they need and want in community. And we also support them in terms of building the relationships they need across all the types of populations that are present in their community. And so in this way, presenting and supporting the vulnerable members of community to have their voice heard in terms of health planning and gap analysis, and also bringing in other agencies that are currently working in community, because we don't want to duplicate, because the health system can't afford that. So lots of work there to support community to engage and plan and discover. We support operations. We support the CHCs to do an evaluation model for quality improvement. And so we have tools and dashboards that they can use. We work a lot in the research space. So currently working with Dr. J over there, Jude, to actually take a look at the community engagement that is underway in the currently operating CHC communities, and figuring out, are there tools and best practices and good methods for community engagement? So we're doing that currently. We're also working with Paul from the BC Rural Health Network to identify, working through a pretty hefty questionnaire to identify in a cross-section of rural communities what assets do they have from a healthcare delivery perspective, what is their gap, do they want a CHC, right? So doing a couple of research projects. We're also doing some research with a couple of universities on team-based care. What does it look like in community? What are the outcomes of team-based care? And how does it ideally save dollars and cents and get us to better health outcomes? We provide different funding models for CHCs, and we are currently negotiating with the Ministry of Health for a sustainable funding model that supports CHCs, and also working with the system to have conversations around what does community engagement in healthcare planning look like, and what are the tools necessary for community engagement in healthcare planning. So we're having those conversations with the system, and taking a look at what we can do to support that, and what the other players in the system need to do to support community engagement. So lots of work going on in that space. And there's me. If you have a friend who wants to develop a community health center, or if you want to know more about it, we also have a website, www.bcatch.org, and there's some tools and research and contacts and all that kind of good stuff on the website. And so you didn't loom. Was I quicker than 6 minutes? All right. Thank you.
Thanks very much, Val. I'm absolutely delighted now to end our panel by introducing Leanne Heppel. She is the Chief Ambulance Officer of BC Emergency Health Services. And I guess the context for this is she's been engaging with the BC Rural Health Network for the past year and a bit, at least, and is exemplifying, from our perspective, the absolute ideal in having our provincial structures engage with rural communities. So I'll let her tell you a little bit more about that. Thanks, Leanne.
Great. Thanks, Jude, and big hello to everyone here. Thanks for joining our session. And yeah, as Jude said, BCEHS is going through a huge transformation, and some of the keys to that transformation is we're on a listening journey and we're on an engagement journey. And so this first slide is really just sort of a summary of the coordination and communication circle of care that we're engaging in. And so in the old days, many of you will know, some of you maybe more so than others, is really you call, we haul. And so we're transforming. That's kind of the slang is what we were known for. But we are transforming the system in a variety of different ways. We're trying to engage across the province to determine what's best care and what's best in communities. And we're also engaging more with our patient partners to really develop a system and service for the future. And so essentially, if you look at the top, if you're involved or your family's involved in an injury or illness, you call 911. And we really want to focus on providing care in your community. Not only care in your community, but also care in your home. We're actually expanding a model that's been going for a few years of community paramedics. We work really closely with the health authorities and also with other healthcare providers in the community. So we're trying to do everything we possibly can to keep you in your home or keep you in your community. There's always an emergency department if needed. And if you look down at the yellow box below, in these smaller rural and remote communities, there will be times when tertiary care or higher level of care is needed. And what we're doing is we're building a treatment and transport strategy, which really has much more greater focus on AIRS. so that we can leave the ground ambulances in the communities to be better equipped to answer the 911 calls in the community and get you air transport to the higher level of care, the care you need. We're also involved in bringing you back to your community, and as I mentioned before, we're really focusing on trying to provide care in the community. We have ambulance stations in about 186 communities across the province. We are looking at, when I first came on, which is about 2 years, I was with BC Ambulance about 12 years ago, and the rest of my career has been in health authorities and also living throughout the province, so I had a pretty good idea of how vast the province was. But now what we're finding is, as opposed to the old model where 60% of all the BCHS employees were actually on call, we're transforming that to now put permanent positions in each of the communities so that we have people living and working in the community, engaging with the community, because that's where they know, that's where they're committed, and we know the care is going to improve with that model. So we started actually a provincial transport advisory committee back in 2018. It's really when we started listening and doing more engagement. And at that time, we did bring in the patient voices networks, all the health authorities, First Nations, BC Women's and Children, because our children and youth and babies are a bit more of a unique transfer, Ministry of Health, Doctors of BC, and it really was, as I said before, listening and hearing what's working, what's not working, and how can we engage better and provide the system that we want. This was remarkable during COVID-19. We had developed a lot of engagement and a lot of partnership before the virus hit, which was really important that we had that strong collaboration and partnership. It really is what sort of kept the province going and ensured that we had the patients moved as quick as possible to the center that could provide the care. We've got some good examples of more recent relationships that we're doing. We're in 186 communities across the province, but we're also expanding that footprint to work with our First Nations, First Nation partners to develop a first responder program so that they could actually learn how to be first responders in areas like the Tahltan Nation, Kitasoo, Bella Coola, so that they can stabilize patients, help keep people in their community, and or stabilize them until BC Ambulance can get there to move them out if that is what's needed. So we're doing a lot of recruiting in the communities and a lot of training in the communities as well. This is a busy slide, but again, it's sort of an example of several years ago where we were on this journey of moving to more of a permanent staffing model as opposed to the on-call model. This was a model, it's called the schedule on-call model, that had to be rolled out quite quickly after a collective agreement ratification, and really there wasn't any engagement or very little engagement. And so, of course, what we found is one size doesn't fit all across the province and our communities, and we quickly knew that we had to pivot and come up with a different model, and so that's what we've done. And we're now spending much more time engaging with the communities to find out what's working, engaging with our employees as well to find out what is the model that's going to work in all of these small communities. In addition to hiring more managers so that our managers have a better opportunity of engaging, we've also developed an Indigenous network, and so we have trained BCEHS Indigenous partners across the province to again tell us what the needs are. I'm also partnering with the Rural Health Network, as Jude said, because that gives me an information to hear at the board meetings and also for me to communicate what are the strategies we're working on and get some feedback and also give an idea of where we're at. So it's helping us. As I said before, we are on a listening journey. We are an engagement journey, and we certainly don't have as much engagement as we'd like, but we believe with increasing our managers in these communities has helped with them getting out there, working with elected municipalities across the province, spending more time with our staff to see what's working, and spending more time with our First Nation communities across the province. In addition to that, as I mentioned, we've got the strength of our patient patient First Nations and Indigenous navigators, which again are helping us with providing more of the uniqueness as to what's needed. And so we believe very firmly that in order to be an effective service, we can't work in isolation. We have to partner. We have to hear what's working, what's not working, whether it's a minor injury or whether it's a catastrophic injury, whether it's rural, remote, or urban or metro. We need to ensure that not only our employees have a chance to tell us what's working, but also the community leaders. This is just a slide to talk about, this is our engagement to date. It is fairly complex. We obviously engage with government, local elected officials, all the unions, all the health authorities, our teaching organizations. We're at UBCM and many of the communities see us there. But we've got a long way to go, and that's one of the reasons why I wanted to be here today, is to find out where we can connect in more. There's so much going on. I learn something new whenever I'm at the board meetings, and it just helps us engage more and build those stronger partnerships. So our transformation, we've been a service for 50 years. We've experienced very little change for the last sort of 48 years. Our anniversary is coming up next year. And in the last 2 years, we've hired over 1,000 employees. We've moved from 60% on call to close to 90% on call. And we are building networks in our communities to listen and to learn and to try and improve on our service, because we feel very strongly that we want to provide the care, the right care at the right time, the first time, and it is different depending on where those patients are. So I'll stop there.
So we have tried to provide some examples of pragmatic engagement with communities driven by evidence-informed practices and policies through our panel. What we're going to do now is have a question period for the panel, but before we go to it, I'm hoping we can all scan the QR code on the screen. It's going to take you to a thought exchange. And I don't know if any of you have participated in thought exchange, but it's your opportunity on your phone to respond to the question, and we've got two of them. The first one is, how do we optimize capturing diverse community voices in research and policy? We've given you lots of examples of policy in this session, so you can just type in some questions. While you're doing that, I'm going to ask the panel to position themselves in the front, and as soon as we give you a minute to make sure you've got the QR code, we're going to turn this off. So you can ask the panel any questions at all. So we'll be toggling back and forth, and to the Daves in the back, I'll check in with you in about 5 minutes to finishing, just to see where the question has got us to, what kind of prioritization happens. But first we'll just give another minute to make sure, I think everybody's got the QR code. So we're going to ask you, Dave, to turn off the screen, and I will be happy to facilitate any questions for our panels. And I think we've got somebody helping with online too. That'll be good. Paul, I see someone with a question.
Thank you. That was a great presentation. Testing. I guess the question is for Paul or any of the panel. Do you see a need for training in patient caregiver community engagement in healthcare for providers and organizations? And how does that fit for rural, as well as do you see a need for training for community and patients in how to engage? And how would that, how do you see that in rural?
I certainly see a need. I see a problem just from an investment perspective in putting money into community engagement for rural. So, you know, as an organization, as a charity, we're doing a lot with a little, and most of our work is volunteer based. I am really the only staff member within the network. I do have outreach contractors who I'm hiring on a per contract basis, so work that we do with Valerie St. John, for example, or work we do with Hope Air. We do get some money, but we really need core funding to go into community engagement and to do education and training in all aspects of that engagement. You know, I'm on a learning journey myself in my daily activity in interacting pan-provincially with communities on how best to change the approach and to make sure that we have the tools and resources needed to engage effectively. But I think the fundamental issue becomes a funding one, and with more resources we could certainly do a lot more.
I'm also going to jump in and answer that question from a scoping review of the evidence on best practices for engaging patients, residents, communities. It is unequivocally clear that there needs to be resources for training because the health system is very complex. To throw people into a context where they don't understand and it's very difficult to understand, the interrelationships is very difficult. The other thing that the evidence says that's really interesting to me is that decision and policymakers also need to be afforded the same opportunity for training to be able to use the yield of community engagement or patient engagement in their policy and planning decisions. So on both levels, yeah, it is. Yeah, good. I think we have some questions online. Is somebody tracking those? No? Yeah, that'd be great. Thank you. If there's a question in the room, great. Go ahead.
I want to piggyback on that, the question about training. And does the Ministry of Health see a need to offer training to care providers? And I'm talking about maybe the nurses or clinicians or so out of that community as opposed to bringing others into the community.
So I'll just jump in and say we actually don't have anybody from the Ministry of Health on the panel. And with, okay, I'm not sure if I can call people out in the room, but we don't have anybody from MOH. And my ministry friend is saying no. So are you okay to answer that, Victoria?
There is an answer over here, Jude.
Good.
I can
Okay.
speak to the work we're doing.
Sure.
Thank you. I can speak to the work that my association is doing with the ministry around talking about, in the context of developing community health centers. So, for example, one of the gaps that we've identified is that there isn't that, in all communities, there isn't the skill set, right, or the resources to do the kind of community engagement that's needed to develop a community health center, say, for example, right? And so my conversations with the ministry has been, gee, if we build it, will you fund it? And then we'll deploy it. And it could be a series of tools for community development. Because ultimately what we would like to see is communities having the skills to be able to do engagement that translates more broadly than just for healthcare planning, right? Community engagement is necessary all across, the ways that communities function. And so these are the conversations my association is in with the Ministry of Health, and there is an interest by the ministry because they recognize that there is this gap in terms of skills and resources. And so, it's our hope that if we find a good set of tools, then we'll be supported to resource the use of those tools so that communities learn how to use them and then can carry on, right? So that is our hope, and I am hopeful given the conversations we've had with the ministry. So I'm not speaking for the ministry, but I'm talking about my experience with them.
That's great. Thank you, Val. We've got some questions online. Leanne, did you want to add to that, or you're just holding the mic?
I was just holding the mic, but I just couldn't. I could now that I've got the mic. I just couldn't resist the comment, though. I just wonder how complex life has become, because I think, when I grew up in small town BC, many small towns. And back in those days, I grew up in a family where we just did everything in the community. So although my dad ran the Overwetty food store, he also drove the ambulance, and he was the volunteer fire. And my mom joined every single volunteer. She had to obviously keep 3 kids in line, but she was the driver for all the school things. And life has just become so complex that we were always having to find ways of coming up with formalized processes. But how do we try to change the narrative and go back to blurring the boundaries and try to get back to the basics in life, where these small, and they weren't actually all those small of communities. I mean, I am getting older. I'm going to say it was 100 years ago, but Fort St. John, Trail, Cranbrook, Mission, Ladysmith on the island, some smaller than others, but they weren't exactly remote centers, and somehow that community just pulled together and made it work. So just a challenge to all of us. How do we make life simpler?
I love it. I'm grabbing the mic now.
Yes, you are.
Just to add to this, that my huge concern is trusting relationships in community. Who are the people that are going to come out in community and actually be a part of this dialogue? And my experience is trying to introduce a group of queer trans youth to police, for example, who really did want to be effective in community. They didn't want to see them. And we had to go through immense work to provide the safety. So safety, it's all built on relationships of trust. So I don't care how many systems we build, we still come down to that fundamental human equation of who's safe, who isn't.
Excellent. I'm going to go to one question online, and it's actually for Paul. And then we're going to have to, there's one question from the audience here, and then we're going to have to wrap up, and we'll just go to the results of the thought exchange. The question for Paul is, Paul, you mentioned pushback and accusations of doing damage to community, of being an agent of the government from some community members. In your experience, what techniques have been helpful to diffuse or to manage these concerns?
Yeah, it's an ongoing daily challenge for me, and I think that you have to switch the narrative. So instead of coming, for example, well, there's lots of examples, but this summer, for example, I was talking about heat waves and how that we were in a drought, and how we were expecting to have a heat dome event similar to a prior event in 2021. Not at the same scale, but it could be quite impactful to our senior population and the most vulnerable within our rural communities. That pushback that came immediately was, you're promoting climate change which doesn't exist, that the government is making this false narrative, and it's all a bunch of hoopla. So rather than getting into a debate about, and I've been in the environmental sector for a long time, so it's a passion issue for me, and it certainly hits the nerve when people push back. But rather than going down that rabbit hole, I just ignored that question and put it back to community values. So I said, all I'm asking is that you go and you check on your neighbor. And in small town life, that's what we do. We check on each other. We can be our primary care provider. And by taking on that role and removing that, then the social media page then engaged with me and said, let's check on people who are most vulnerable, and let's do that. And the whole narrative of the conversation changed. And it's again, it's a matter of, instead of coming top down, go back in through the bottom of the community and come from the bottom up.
Thanks, Paul. So we've got one last question from Myrna. Go ahead.
Sure. My concern is the elephant in the room, and that's dementia. Everybody now knows somebody with dementia. It's a tsunami for our government, whether that's federal or provincial. The things that you guys are talking about today, where communities, and I like to think of it, neighborhoods going in and helping each other, could be promoted by people like you. Because I think the healthcare system has made it so frightful for people describing people like me who might be weird in some way, like you all are. So we really need to have people like you, advocates like you, talk about going back to the neighborhood for our health care. Thanks.
Absolutely, thank you. So we're almost out of time. I'm wondering if we can just quickly switch on the screen to see if we have any prioritization of some of the answers in response to the first question. If that's possible, Dave. Okay. Great. Can we go to all thoughts for a minute and just scroll through them really quickly? So I see a theme about trying to connect with rural communities. And absolutely, if we had more time, I would love to talk about some tips and strategies for engaging with rural communities, because as we hear, a lot of policy and decision makers are doing it, and researchers are doing it off the side of their desks. Yeah. Yeah, a lot of what we've talked about, this is great. Share the results of research on what communities say is the best engagement for them. And that's actually where it starts. When we talk about respectful engagement, it's asking in every community how they want to be engaged, for sure. And again, emphasizing that we're coming from a rural perspective, but it's community of like interest as well that we can be talking about. Listening, yep. Yeah. So that number 16 is actually really interesting, sharing learnings about community needs across different policy and service organizations. We tend to work very siloed, and that's one of the traditions, I guess, that we're all trying to break. We're trying to work between BC Emergency Health Services, between BCATCH, between the BC Rural Network, between the Centre for Rural Health Research, to bring it all together. One of the things that's very clear is that it's very easy to overburden, especially small communities. So if we're all engaging separately, that provides an ownersome task for the communities who are trying to respond to the engagement. So collaborating more before engagement even happens is really important. Yeah. Yeah, the issue of tokenism comes up a lot, and that's one of the things we've often said. We really, really need to the inclusion of patient voices in healthcare planning and healthcare research, at the risk of them being tokenistic. We suggest expanding out. We need that individual voice. We also need to put it in aggregate to the sum total of patient experience. Otherwise, we're looking through a very narrow lens of an individual. Okay. Oh gosh, is there a lot more? I'm appreciative that I'm in between you and lunch. Yeah. Okay. Great response. Hopefully, through the conference organizers, we can make this available to people so we can share it across platforms. And thank you for such amazing questions and a really, really, really good discussion. And of course, thanks to the panel.